Question 1. A 68-year-old male is admitted with acute exacerbation of chronic systolic congestive heart failure. He also has documented type 2 diabetes mellitus with diabetic nephropathy and a long-standing history of atrial fibrillation. What is the correct principal diagnosis for this admission? A. I50.23, acute on chronic systolic congestive heart failure. B. I50.21, acute systolic congestive heart failure. C. I50.9, heart failure unspecified. D. E11.22, type 2 diabetes mellitus with diabetic nephropathy. Answer. A. I50.23, acute on chronic systolic congestive heart failure. Explanation. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. In this scenario, the patient is admitted due to an acute exacerbation of his chronic systolic heart failure, which is explicitly coded as I50.23. While the patient has multiple comorbidities, the acute on chronic systolic heart failure is the primary reason for this specific inpatient admission. Correctly identifying the principal diagnosis is crucial for accurate MSDRG assignment and reimbursement. Question 2. A patient presents for excision of a sebaceous cyst from the scalp. The documentation states the cyst was 2.5 centimeters and was excised without complications. What is the correct CPT code for this procedure? A. 11403, excision, benign lesion including margins, except skin tag, unless listed elsewhere. Trunk, arms, legs, excised diameter 2.1 to 3.0 centimeters. B. 11423, excision, benign lesion including margins, except skin tag, unless listed elsewhere. Scalp, neck, hands, feet, genitalia, perineum. Excised diameter 2.1 to 3.0 centimeters. C. 11,000, debridement of extensive eczematous or infected skin, up to 10% of body surface. D. 11603, excision, malignant lesion including margins, trunk, arms, legs, excised diameter 2.1 to 3.0 centimeters. Answer. B. 11423, excision, benign lesion including margins, except skin tag, unless listed elsewhere. Scalp, neck, hands, feet, genitalia, perineum, excised diameter 2.1 to 3.0 centimeters. Explanation. To correctly code the excision of a sebaceous cyst, which is a benign lesion, it is essential to consider both the size of the lesion and its anatomical location. CPT codes for benign lesion excisions are stratified by body area and excised diameter. In this case, the cyst is on the scalp, a specified anatomical location, and has an excised diameter of 2.5 centimeters, falling within the 2.1 to 3.0 centimeters range for code 11423. Selecting the correct code ensures accurate representation of the procedure performed and appropriate reimbursement. Question 3. A patient undergoes an open cholecystectomy. During the procedure, the physician notes severe adhesions from a previous surgery, requiring significant additional time and effort for lysis. What CPT modifier should be considered for reporting the increased procedural complexity? A. Modifier 22, increased procedural service. B. Modifier 51, multiple procedures. C. Modifier 52, reduced services. D. Modifier 59, distinct procedural service. Answer. A. Modifier 22, increased procedural service. Explanation. Modifier 22 is used to indicate that a service provided was substantially greater than typically required, often due to unusual circumstances, increased intensity, time, technical difficulty, or patient severity. The documentation of severe adhesions requiring significant additional effort during an open cholecystectomy is a classic example of when modifier May 22nd be appropriate. Proper use of this modifier, supported by comprehensive medical record documentation, allows for potential increased reimbursement that reflects the true complexity of the procedure, ensuring fair compensation for the physician's extended work. Question 4. A patient is admitted with a hip fracture sustained in a fall at home. The patient has a history of severe osteoporosis. What is the correct sequencing of diagnoses according to ICD-10 CM guidelines? A. M80.08XA, age-related osteoporosis with current pathological fracture, other specified site, initial encounter. S72.009A, unspecified fracture of unspecified part of neck of femur, initial encounter for closed fracture. B. S72.009A, unspecified fracture of unspecified part of neck of femur, initial encounter for closed fracture. M80.08XA, age-related osteoporosis with current pathological fracture, other specified site, initial encounter. C. M80.08XA, age-related osteoporosis with current pathological fracture, other specified site, initial encounter. R29.5, unspecified falls. D. S72.009A, unspecified fracture of unspecified part of neck of femur, initial encounter for closed fracture. M81.0, age-related osteoporosis, without current pathological fracture. Answer. AM 80.08XA, age-related osteoporosis with current pathological fracture, other specified site, initial encounter. S72.009A, unspecified fracture of unspecified part of neck of femur, initial encounter for closed fracture. Explanation. According to ICD-10 CM Guideline ID C.13 A code from category M80, osteoporosis with current pathological fracture, should be sequenced first when the patient has osteoporosis and a pathological fracture, even if the fracture resulted from a fall. The fall itself is not the primary cause of the fracture in the context of osteoporosis, but rather the osteoporosis makes the bone susceptible to fracture from minimal trauma. The fracture code, S72.009A, is then coded second to specify the site of the fracture, clearly indicating the underlying bone pathology as the primary condition responsible for the fracture. Question 5. Which of the following describes the root operation, excision in ICD-10 PCS? A. Cutting out or off, without replacement, a portion of a body part. B. Taking or letting out fluids and or gases from a body part. C. Removing all or a portion of a body part without replacement. D. Freeing a body part from an abnormal physical constraint. Answer. A. Cutting out or off, without replacement, a portion of a body part. Explanation. In ICD-10 PCS, the root operation excision is specifically defined as cutting out or off, without replacement, a portion of a body part. This is distinct from resection, which involves removing all of a body part. Understanding the precise definitions of root operations is fundamental to accurate PCS coding, as misinterpreting these definitions can lead to incorrect code assignments. Mastering these distinctions ensures the coded procedure accurately reflects the surgeon's intent and action. Question 6. A patient presents to the emergency department with abdominal pain, nausea, and vomiting. After evaluation, the physician determines the patient has acute appendicitis. An appendectomy is performed. What is the correct present on admission, POA, indicator for the diagnosis of acute appendicitis? AY yes. BN no. CU unknown. DW clinically undetermined. Answer. AY yes. Explanation. The present on admission, POA, indicator, Y signifies that the condition was present at the time the order for inpatient admission occurred. In this scenario, the patient presented to the emergency department with symptoms of acute appendicitis, and the diagnosis was confirmed upon evaluation, meaning the condition existed before the official inpatient admission. Accurately assigning POA indicators is critical for hospital quality measures and reimbursement, as conditions not POA can be subject to payment penalties. Question 7. A patient undergoes a complete colonoscopy, and a polyp is identified and removed by snare technique from the descending colon. What is the correct CPT code for this procedure? A. 45378, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing. When performed, separate procedure, with biopsy, single or multiple. B. 45385, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing. When performed, separate procedure, with removal of tumors, polyps, or other lesions by snare technique. C. 45380, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing. When performed, separate procedure, with endoscopic mucosal resection. D. 45,378-52, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing. When performed, separate procedure, with biopsy, single or multiple, reduced services. Answer. B. 45385, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing. When performed, separate procedure, with removal of tumors, polyps, or other lesions by snare technique. Explanation. When a polyp is removed during a colonoscopy, the correct CPT code reflects the most extensive procedure performed. In this case, the removal of a polyp by snare technique supersedes a simple diagnostic colonoscopy or a colonoscopy with biopsy. Code 45385 specifically describes a colonoscopy with removal of lesions by snare technique, making it the most appropriate choice. Understanding CPT bundling rules and the hierarchy of endoscopic procedures is essential to prevent unbundling and ensure accurate coding practices. Question 8. What is the primary purpose of the National Correct Coding Initiative and CCI edits? A. To prevent unbundling of services and ensure appropriate payment for Medicare services. B. To determine the medical necessity of services provided to Medicare beneficiaries. C. To establish national guidelines for physician credentialing. D. To track the prevalence of specific diseases across the Medicare population. Answer. A. To prevent unbundling of services and ensure appropriate payment for Medicare services. Explanation. The National Correct Coding Initiative and CCI was developed by CMS to promote national correct coding methodologies and control improper coding leading to inappropriate payment in Medicare Part B claims. Its primary purpose is to prevent unbundling of services, ensuring that procedures typically performed together are not billed separately and that services inherent to a more comprehensive procedure are not separately reimbursed. Adherence to NCCI edits is a critical aspect of coding compliance, directly impacting claims processing and preventing fraud and abuse. Question 9. A patient is admitted for intractable nausea and vomiting due to chemotherapy for metastatic colon cancer. The dehydration is noted as severe. What is the correct principal diagnosis for this inpatient admission? A. R11.2, nausea with vomiting, intractable. B. T45.1x5, adverse effect of antineoplastic and immunosuppressive drugs, initial encounter. C. C18.9, malignant neoplasm of colon, unspecified. D. E86.0, dehydration. Answer. B. T45.1x5, adverse effect of antineoplastic and immunosuppressive drugs, initial encounter. Explanation. When an admission is specifically for the management of an adverse effect or complication of chemotherapy, the adverse effect code is typically sequenced as the principal diagnosis. In this scenario, the intractable nausea and vomiting are a direct result of the antineoplastic therapy, making T45.1x5 the most appropriate principal diagnosis. The specific manifestation, R11.2, and the underlying malignancy, C18.9, would then be coded as secondary diagnoses. This sequencing accurately reflects the primary reason for the patient's admission and aligns with ICD-10-CM guidelines regarding complications of care. Question 10. In ICD-10-PCS, which approach involves entry by cutting through the skin or mucous membrane and any other body layers necessary to expose the site of the procedure? A. Open. B. Percutaneous. C. External. D. via natural or artificial opening endoscopic? Answer: A. Open. Explanation: the open approach in ICD-10 PCS is defined as entry by cutting through the skin or mucous membrane and any other body layers necessary to expose the site of the procedure. This is a direct method of accessing the body part for surgical intervention. Understanding the specific definitions for each approach is crucial for accurate PCS coding, as the choice of approach significantly impacts the final code assigned. Misinterpreting approaches can lead to incorrect data capture for statistical and reimbursement purposes. Question 11. Which modifier is appropriately used when a physician performs a bilateral procedure, such as a bilateral mammogram? A. Modifier 50, bilateral procedure. B. Modifier 51, multiple procedures. C. Modifier 26, professional component. D. Modifier 76, repeat procedure or service by same physician or other qualified healthcare professional. Answer: A. Modifier 50, bilateral procedure. Explanation: Modifier 50 is specifically used to report bilateral procedures that are performed during the same operative session. When a procedure is inherently bilateral, or when a unilateral procedure is performed on both sides, Modifier 50 indicates that the service was performed on paired organs or on both sides of the body. This helps payers understand that the service was more extensive than a unilateral procedure and prevents billing for two separate unilateral procedures, which could be seen as unbundling. Correct application of this modifier streamlines claims processing and ensures appropriate reimbursement for services. Question 12. A patient is seen for a follow-up visit after a recent myocardial infarction, MI, which occurred 6 weeks ago. The patient is stable. What is the appropriate ICD-10 CM code for the MI in this follow-up encounter? A. I-21.9, acute myocardial infarction, unspecified. B. I-25.2, old myocardial infarction. C. I-22.0, subsequent STEMI of anterior wall myocardial infarction. D. I-21.A1, STEMI myocardial infarction. Answer: B. I-25.2, old myocardial infarction. Explanation: for follow-up visits after a myocardial infarction, once the acute phase, typically within 4 weeks, has passed, the appropriate code for the MI is I-25.2, old myocardial infarction. This code indicates a history of an MI rather than a current acute event. Since the MI occurred 6 weeks ago, it falls outside the acute phase. The acute MI codes, I-21, are used for the initial episode of care within 28 days, while I-22 codes are for subsequent MIs within the 28-day window. Accurately coding the stage of the MI is essential for proper patient care documentation and data analysis. Question 13. According to ICD-10 CM guidelines, when a patient is admitted for chemotherapy, what is the correct principal diagnosis? A. The malignancy code, e.g., C50.919. B. Z51.11, encounter for antineoplastic chemotherapy. C. A code for any documented symptoms or complications, e.g., R53.81, constitutional symptoms. D. The underlying reason for the malignancy, if known. Answer: B. Z51.11, encounter for antineoplastic chemotherapy. Explanation: when a patient's primary reason for admission or encounter is to receive chemotherapy, radiation therapy, or immunotherapy, the appropriate Z code, e.g., Z51.11 for chemotherapy, is sequenced as the principal diagnosis. The malignancy code should then be sequenced as a secondary diagnosis, even if it is still active. This sequencing accurately reflects that the focus of the encounter is the treatment itself, rather than the initial diagnosis of the disease. Following this guideline is critical for correct reporting of treatment encounters and appropriate reimbursement. Question 14. Which of the following would be coded as an external approach in ICD-10 PCS? A. Application of a cast. B. Reduction of a fracture via incision. C. Laparoscopic appendectomy. D. Insertion of a central venous catheter. Answer: A. Application of a cast. Explanation: the external approach in ICD-10 PCS refers to procedures performed directly on the skin or mucous membrane, or indirectly by applying external force or pressure through the skin or mucous membrane. The application of a cast for a fracture is a prime example of an external approach, as the intervention is performed externally without making an incision to reach the body part. Correctly identifying the approach is vital for accurate PCS coding, ensuring that the coded procedure precisely matches the physician's documented method. Question 15. A 45-year-old male undergoes removal of hardware from his left tibia, which was placed 6 months prior for a fracture. The hardware includes a plate and screws. What CPT code series would be most appropriate for this procedure? A. 20680, removal of implant. Deep, e.g., buried wire, pin, screw, metal band, nail, rod or plate. B. 20670, removal of implant. Superficial, e.g., buried wire, pin or screw, not requiring skin incision. C. 27704, removal of implant. Tibia, fibula, requiring incision. D. 27724, repair of non-union or malunion, tibia, with or without graft, anterior approach. Answer: A. 20680, removal of implant. Deep, e.g., buried wire, pin, screw, metal band, nail, rod or plate. Explanation: the removal of internal fixation devices, such as plates and screws, from a deep bone like the tibia requires a specific CPT code. Code 20680 is used for the removal of deep implants, which are typically buried within the bone or deep tissues and require an incision for removal. This contrasts with superficial implants that may be removed without an incision, 20670, or more complex procedures involving bone repair. Selecting the precise code reflecting the depth and nature of the implant removal ensures accurate representation of the surgical effort and appropriate reimbursement. Question 16. Which of the following best describes a principal procedure in the context of inpatient hospital coding? A. The procedure most closely related to the principal diagnosis. B. The procedure that is performed for definitive treatment rather than for diagnostic or exploratory purposes, or to treat a complication. C. Any procedure performed during the inpatient stay. D. The most resource-intensive procedure performed. Answer: B. The procedure that is performed for definitive treatment rather than for diagnostic or exploratory purposes, or to treat a complication. Explanation: according to ICD-10 PCS official guidelines for coding and reporting, B3.2, the principal procedure is defined as the procedure performed for definitive treatment rather than for diagnostic or exploratory purposes, or to treat a complication. If there are multiple procedures that could be considered definitive, the one most related to the principal diagnosis is chosen. This definition ensures consistency in identifying the main intervention for an inpatient stay, which is crucial for correct MSDRG assignment and subsequent hospital reimbursement. Question 17. A patient with a history of hypertension and type 2 diabetes mellitus is admitted due to a severe urinary tract infection, UTI, with sepsis. The sepsis is documented as severe. What is the correct sequencing of diagnoses? A 41.9, sepsis, unspecified organism, and 39.0, urinary tract infection, site not specified, R 65.20, severe sepsis without septic shock. B and 39.0, urinary tract infection, site not specified, a 41.9, sepsis, unspecified organism, R 65.20, severe sepsis without septic shock. C, R 65.20, severe sepsis without septic shock, a 41.9, sepsis, unspecified organism, N 39.0, urinary tract infection, site not specified. D, a 41.9, sepsis, unspecified organism, R 65.20, severe sepsis without septic shock, N 39.0, urinary tract infection, site not specified. Answer: D. A 41.9, sepsis, unspecified organism. R 65.20, severe sepsis without septic shock. And 39.0, urinary tract infection, site not specified. Explanation: according to ICD-10 CM guidelines for sepsis, IC.1.A.1-B, when sepsis develops from an infection, such as a UTI, the systemic infection, a 41.9 sepsis unspecified organism, is sequenced first, followed by the code for the localized infection, and 39.0 urinary tract infection. Furthermore, if severe sepsis is present, a code from subcategory R65.2, severe sepsis, is added as a secondary diagnosis to describe the severity. Therefore, the most accurate sequence is sepsis, then severe sepsis, then the localized infection that caused it. This order correctly reflects the hierarchy and progression of the conditions. Question 18. What is the appropriate ICD-10 CM code for a screening mammogram for a high-risk patient with a family history of breast cancer? A. Z12.31, encounter for screening mammogram for malignant neoplasm of breast. B. Z80.3, family history of malignant neoplasm of breast. C. R92.8, other abnormal findings on diagnostic imaging of breast. D. Z12.39, encounter for other screening for malignant neoplasm of breast. Answer: A. Z12.31, encounter for screening mammogram for malignant neoplasm of breast. Explanation: when a patient undergoes a screening mammogram, the primary reason for the encounter is the screening itself. Therefore, the appropriate code for a screening mammogram is Z12.31, encounter for screening mammogram for malignant neoplasm of breast. The family history of breast cancer, Z80.3, would be coded as a secondary diagnosis, providing context for why the patient is considered high risk for screening. Accurate use of Z codes for screenings is vital for appropriate billing and demonstrating compliance with preventive care guidelines. Question 19. A patient presents for a diagnostic colonoscopy. During the procedure, the physician notes several small polyps, but does not remove them. A biopsy is taken from one of the polyps. What CPT code should be reported? A. 45378, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing, when performed, separate procedure, with biopsy, single or multiple. B. 45,378-52, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing, when performed, separate procedure, with biopsy, single or multiple, reduced services. C. 45385, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing, when performed, separate procedure, with removal of tumors, polyps, or other lesions by snare technique. D. 45378 and 45380. Answer: A. 45378, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing, when performed, separate procedure, with biopsy, single or multiple. Explanation: when a diagnostic colonoscopy is performed and a biopsy is taken, the correct CPT code is 45378. This code encompasses a diagnostic colonoscopy that includes the collection of specimens by biopsy, regardless of whether a single or multiple biopsies are taken. It's important to remember that if the polyps were removed, a different code, like 45385 for snare removal, would be used. Selecting the appropriate code based on the most comprehensive procedure performed is essential for accurate CPT reporting and preventing billing errors. Question 20. In ICD-10 PCS, which root operation describes, putting in or on a therapeutic, prophylactic, or diagnostic device? A. Insertion. B. Bypass. C. Restriction. D. Supplement. Answer: A. Insertion. Explanation: the root operation insertion in ICD-10 PCS is specifically defined as putting in or on a therapeutic, prophylactic, or diagnostic device. This includes procedures like inserting a pacemaker, an intra-aortic balloon pump, or an endotracheal tube. Understanding the precise definitions of root operations is fundamental to accurate PCS coding, as misinterpreting these definitions can lead to incorrect code assignments. Mastering these distinctions ensures the coded procedure accurately reflects the surgeon's intent and action. Question 21. A patient is admitted for acute diverticulitis with perforation and abscess. An emergency laparotomy with partial colectomy and colostomy creation is performed. What is the correct principal diagnosis? A. K57.21. Diverticulitis of large intestine with perforation with abscess, without hemorrhage. B. K57.20. Diverticulitis of large intestine with perforation without abscess, without hemorrhage. C. K57.30. Diverticulitis of small intestine with perforation without abscess, without hemorrhage. D. K57.92. Diverticulitis of intestine, unspecified, with perforation with abscess, without hemorrhage. Answer. A. K57.21. Diverticulitis of large intestine with perforation with abscess, without hemorrhage. Explanation. When a patient is admitted with acute diverticulitis that includes complications like perforation and an abscess, the code representing the most severe condition and causing the admission should be the principal diagnosis. K57.21 specifically captures diverticulitis of the large intestine with both perforation and abscess. This detailed code accurately describes the primary reason for the patient's emergent admission and subsequent surgery. Correct principal diagnosis selection is crucial for accurate MSDRG assignment and appropriate hospital reimbursement. Question 22. Which of the following scenarios would most likely require the use of CPT modifier 25? A. A patient presents for a routine checkup, and the physician identifies and treats a new, unrelated sprained ankle during the same visit. B. A surgeon performs a scheduled hernia repair and, during the same operative session, excises a skin lesion from the patient's arm. C. A patient receives an injection, and the physician performs the associated evaluation and management service. D. A physician performs a procedure in the morning and then repeats the same procedure later that day due to a complication. Answer. A. A patient presents for a routine checkup, and the physician identifies and treats a new, unrelated sprained ankle during the same visit. Explanation. Modifier 25 indicates that a significant, separately identifiable evaluation and management (E/M) service was performed by the same physician on the same day as another procedure or service. The key is that the E/M service must be above and beyond what is typically included with the procedure. In the scenario where a patient has a routine checkup and a new, unrelated problem is addressed, the E/M for the new problem would warrant modifier 25 when billed with the routine E/M code. This ensures proper reimbursement for both the preventive service and the problem-focused E/M. Question 23. According to ICD-10 CM official guidelines, when a patient has both chronic kidney disease, CKD, and hypertension, and the physician documents hypertensive chronic kidney disease, unspecified stage, what is the correct sequencing? A. I-12.0, hypertensive chronic kidney disease with stage 1 through stage for chronic kidney disease or unspecified chronic kidney disease, and 18.9, chronic kidney disease unspecified. B. N 18.9, chronic kidney disease unspecified, I-10, essential, primary, hypertension. C. I-10, essential, primary, hypertension, and 18.9, chronic kidney disease unspecified. D. I-13.10, hypertensive heart and chronic kidney disease without heart failure, with stage 1 through stage for chronic kidney disease or unspecified chronic kidney disease, I-10, essential, primary, hypertension. Answer. AI-12.0, hypertensive chronic kidney disease with stage 1 through stage for chronic kidney disease or unspecified chronic kidney disease, and 18.9, chronic kidney disease unspecified. Explanation. ICD 10 cm coding guidelines specify that when a patient has both hypertension and chronic kidney disease and the documentation explicitly links them, e.g., hypertensive chronic kidney disease unspecified stage, a combination code from category I-12, hypertensive chronic kidney disease, should be used. The guideline ID C.9.A.1 states that the appropriate code from I-12 should be sequenced first, followed by the appropriate stage of chronic kidney disease from category N18. Therefore, I-12.0 for unspecified stage of CKD due to hypertension, followed by N18.9 is the correct sequence. This combination coding approach accurately reflects the relationship between the two conditions. Question 24. Which component is not typically considered part of the CPT surgical global package? A. The initial evaluation and management, E/M, visit that establish the need for surgery. B. Intraoperative services that are normally a usual component of the surgical procedure. C. Preoperative visits immediately prior to the surgery, e.g., day of or day before. D. Postoperative care for a specified period, e.g., 90 days for major surgery. Answer. A. The initial evaluation and management, E/M, visit that establish the need for surgery. Explanation. The initial evaluation and management, E/M, visit that established the need for surgery and resulted in the decision to perform the surgery is generally not included in the CPT's surgical global package. If this E/M visit occurs on the same day as the surgery or within the global period, it can be reported separately using modifier 57, decision for surgery. The global package typically includes preoperative visits immediately prior to surgery, intraoperative services, and routine postoperative care. Understanding what is included in the global package is critical for preventing unbundling and ensuring appropriate billing. Question 25. A patient with type 2 diabetes mellitus is admitted with diabetic ketoacidosis, DKA, and hyperglycemia. The DKA is the primary reason for admission. What is the correct principal diagnosis? A. E11.10, type 2 diabetes mellitus with ketoacidosis without coma. B. E11.65, type 2 diabetes mellitus with hyperglycemia. C. E11.9, type 2 diabetes mellitus without complications. D. R73.01, impaired fasting glucose. Answer. A. E11.10, type 2 diabetes mellitus with ketoacidosis without coma. Explanation. When a patient with type 2 diabetes mellitus is admitted for diabetic ketoacidosis, DKA, the combination code that specifically identifies the diabetes with ketoacidosis should be used as the principal diagnosis. E11.10 accurately captures type 2 diabetes with ketoacidosis without coma, which is the most severe and primary reason for this admission. While hyperglycemia is present, DKA represents a more acute and complex metabolic decompensation. Correctly identifying the most specific and severe condition as the principal diagnosis is crucial for accurate MSDRG assignment and proper reimbursement. Question 26. In ICD-10 PCS, which body system is represented by the character 0? A. Central nervous system. B. Heart and great vessels. C. Upper arteries. D. Gastrointestinal system. Answer. A. Central nervous system. Explanation. The first character in an ICD-10 PCS code represents the medical and surgical section, and the second character identifies the body system. The character 0 specifically corresponds to the central nervous system, body system in ICD-10 PCS. Memorizing and understanding the body system characters is a foundational skill in PCS coding, as it is the first step in constructing accurate procedural codes. Incorrectly identifying the body system will result in an invalid or erroneous code. Question 27. A physician performs a complex repair of a 6.0 centimeters laceration of the patient's forearm. The repair involved significant debridement and extensive undermining. What CPT code should be reported? A. 12032, repair, intermediate, wounds of scalp, axilla, trunk and/or extremities, excluding hands and feet, 2.6 centimeters to 7.5 centimeters. B. 13121, repair, complex, scalp, arms, and/or legs, 2.6 centimeters to 7.5 centimeters. C. 12002, repair, superficial, wounds of scalp, neck, axilla, trunk, and/or extremities, excluding hands and feet, including digits, 2.6 centimeters to 5.0 centimeters. D. 13101, repair, complex, trunk, 2.6 centimeters to 7.5 centimeters. Answer. B. 13121, repair, complex, scalp, arms, and/or legs, 2.6 centimeters to 7.5 centimeters. Explanation. For wound repairs, CPT coding distinguishes between superficial, intermediate, and complex repairs. Complex repairs involve more than just simple closure, such as extensive undermining, scar revision, or debridement, and are coded based on location and size. Given the documentation of complex repair on the forearm and extremity, measuring 6.0 centimeters, code 13121, repair, complex, scalp, arms, and/or legs, 2.6 centimeters to 7.5 centimeters, is the most appropriate choice. Proper classification by complexity, size, and anatomical site is crucial for accurate reimbursement. Question 28. What is the primary function of the alphabetic index in ICD-10-CM? A. To provide a comprehensive list of all valid ICD-10-CM codes. B. To locate the main term for a diagnosis or condition, which then directs the coder to the tabular list for code verification. C. To identify the principal diagnosis for inpatient hospital admissions. D. To provide guidelines for sequencing multiple diagnoses. Answer. B. To locate the main term for a diagnosis or condition, which then directs the coder to the tabular list for code verification. Explanation. The alphabetic index in ICD-10-CM serves as the initial entry point for locating diagnostic codes. Its primary function is to list diseases, conditions, and other diagnostic terms in alphabetical order, guiding the coder to the most appropriate main term. From there, the coder is directed to the tabular list, where the full code, including all necessary characters and official guidelines, must be verified before final assignment. This two-step lookup process ensures accurate and complete code selection, adhering to established coding conventions. Question 29. A patient is admitted for treatment of a non-healing surgical wound from an appendectomy performed 2 weeks prior. The wound is documented as infected. What is the correct principal diagnosis? A. T81.4 XXA, infection following a procedure, initial encounter. B. L0 3.116, cellulitis of abdominal wall. C. K37, unspecified appendicitis. D. Z48.815, encounter for surgical aftercare following surgery on the digestive system. Answer. A. T81.4 XXA, infection following a procedure, initial encounter. Explanation. When an admission is primarily for a complication of a surgical procedure, such as a non-healing, infected surgical wound, the complication code should be sequenced as the principal diagnosis. T81.4 XXA, infection following a procedure, accurately captures the primary reason for this inpatient encounter. While the wound may have signs of cellulitis, L0 3.116, the root cause is the post-procedural infection, which takes precedence. Correctly identifying and sequencing post-procedural complications is critical for accurate MSDRG assignment and appropriate hospital reimbursement. Question 30. Which modifier is used to indicate that the professional component of a diagnostic test was performed? A. Modifier 26, professional component. B. Modifier TC, technical component. C. Modifier 52, reduced services. D. Modifier 59, distinct procedural service. Answer. A. Modifier 26, professional component. Explanation. Modifier 26 is specifically appended to CPT codes to indicate that only the professional component of a service was provided. This applies to services that have both a technical component, e.g., equipment, supplies, and technician services, and a professional component, e.g., physician's interpretation and report. For instance, when a radiologist interprets an X-ray performed at an independent diagnostic facility, only the professional component, 26, is billed by the radiologist. Correct use of this modifier is essential for accurate billing and appropriate reimbursement in shared service environments. Question 31. In ICD-10 PCS, what is the meaning of the root operation release? A. Freeing a body part from an abnormal physical constraint by cutting or by use of force. B. Cutting out or off, without replacement, a portion of a body part. C. Taking or letting out fluids and or gases from a body part. D. Putting back in or on all or a portion of a separated body part to its normal location. Answer. A. Freeing a body part from an abnormal physical constraint by cutting or by use of force. Explanation. The root operation release in ICD-10 PCS is defined as freeing a body part from an abnormal physical constraint by cutting or by use of force. This typically involves procedures like adhesiolysis, neurolysis, or tenolysis, where adhesions or strictures are divided to restore normal function. It is important to distinguish release from division, which involves cutting into a body part without severing it. Understanding precise root operation definitions is crucial for selecting the correct PCS code and accurately representing the surgical intervention. Question 32. A patient undergoes an open reduction and internal fixation of a bimalleolar ankle fracture. The physician performs arthroscopy of the ankle joint prior to the open repair to assess cartilage damage. How should these procedures be coded? A. Code the open reduction and internal fixation only, as arthroscopy is bundled. B. Code both the arthroscopy and the open reduction and internal fixation, with modifier 59 on the arthroscopy. C. Code the arthroscopy only, as it was performed first. D. Code both procedures, without any modifiers. Answer. B. Code both the arthroscopy and the open reduction and internal fixation, with modifier 59 on the arthroscopy. Explanation. When an arthroscopic procedure is performed and is a distinct service from an open procedure in the same anatomical area, it may be separately reportable with modifier 59, distinct procedural service. In this scenario, the arthroscopy was performed for diagnostic purposes to assess cartilage damage prior to the open repair, making it a separate and distinct service not usually included in the open procedure. Appending modifier 59 to the arthroscopy code indicates it was performed for a reason independent of the open fixation. This ensures proper reimbursement for both services when supported by thorough documentation. Question 33. What is the correct ICD-10 CM code for acute sinusitis on specified site? A. J0 1.90. B. J32.9. C. J0 1.00. D. J00. Answer. A. J0 1.90. Explanation. The correct ICD-10 CM code for acute sinusitis unspecified site is J0 1.90. This code specifically captures an acute form of sinusitis when the particular sinus affected is not specified in the documentation. J32.9 is for chronic sinusitis, J0 1.00 is for acute maxillary sinusitis, and J00 is for acute nasopharyngitis. Choosing the most specific code that accurately reflects the documented condition is a fundamental principle of ICD-10 CM coding, ensuring precise data for healthcare statistics and reimbursement. Question 34. A patient receives a follow-up injection for chronic back pain from an established patient. The physician documents a brief examination and administers the injection. What CPT E/M code, if any, should be reported in addition to the injection code? A. 99212. office or other outpatient visit for the evaluation and management of an established patient, which requires at least two of three key components: a problem-focused history, a problem-focused examination, straightforward medical decision-making. B. 99213, office or other outpatient visit for the evaluation and management of an established patient, which requires at least two of three key components: an expanded problem-focused history, an expanded problem-focused examination, low-complexity medical decision-making. C. No E/M code should be reported, as the E/M is inherent to the injection. D. 99202, office or other outpatient visit for the evaluation and management of a new patient, which requires at least two of three key components: an expanded problem-focused history, an expanded problem-focused examination, straightforward medical decision-making. Answer: A. 99212, office or other outpatient visit for the evaluation and management of an established patient, which requires at least two of three key components: a problem-focused history, a problem-focused examination, straightforward medical decision-making. Explanation: when an established patient receives an injection and the physician performs a separately identifiable evaluation and management E/M service beyond simply administering the injection, an E/M code can be reported with modifier 25. A brief examination to determine the need for the injection and monitor the patient's condition typically supports a problem-focused E/M level, such as 99212. If only the injection was given without any significant E/M, then only the injection code would be reported. Accurate reporting requires careful assessment of whether the E/M was significant and separately identifiable from the procedure itself. Question 35. Which of the following conditions would generally not be assigned a present on admission, POA, indicator of why? Yes? A. Hospital-acquired pneumonia. B. Community-acquired pneumonia diagnosed at admission. C. Acute myocardial infarction upon presentation TED. D. Diabetic ketoacidosis upon presentation TED. Answer: A. Hospital-acquired pneumonia. Explanation: the present on admission, POA, indicator, why, yes, signifies that the condition was present at the time the order for inpatient admission occurred. Hospital-acquired pneumonia, HAP, by its very definition, develops after the patient's admission to the hospital and would therefore typically be assigned a POA indicator of and no. Conditions like community-acquired pneumonia, acute MI, or DKA, when diagnosed upon presentation, are present at the time of admission. Correctly assigning POA indicators is critical for hospital quality reporting and reimbursement, as many hospital-acquired conditions are subject to payment penalties.